Okay, so Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everyone. Welcome to the Pediatric GI Academy. It's really an honor and pleasure to introduce the guest speaker for tonight, Dr. Rohit Kohli. Dr. Rohit Kohli, he's a well-known and famous pediatric gastroenterologist. He's one of the expertise in liver disease. He's a chief division of gastroenterology and hepatology and nutrition at the Children's Hospital of Los Angeles. His research work has focused on liver disease, mainly obesity related to fatty liver disease. He has a numerous publication, books, chapters. We are really glad to have you with us, Dr. Rohit, and we are very excited about your talk. I'm sure a lot of the audience heard about you and excited to hear from you. And thank you again for accepting our invitations. The mic is yours.
Thank you so much for the generous introduction and so kind of you to invite me, especially that I don't have to wake up in the middle of the night,
Mhm.
typically when we do these things. I'm glad this is able to be facilitated and it's not too late for you either. Uh, the topic that I was asked to discuss today has been really active in the research space and new therapeutic space recently, after a long hiatus of some status quo in pediatrics, which is acute liver failure in children. So I really felt this is a timely opportunity to share some of our work and some of the things we think are still needing to be done. Here's my disclosures. I do consult for a couple of companies. I will not be speaking to any of these today. They're more in the bile acid fatty liver space. The outline of my talk is why, what, and what next. A very straightforward outline. So in terms of why is because we all are pediatricians interested in acute liver failure, in liver disease in children. So we are here for the right reason. We want to learn more about this. Back in 1999, the National Institutes of Health put forth a initiative called the Pediatric Acute Liver Failure Group or Study Group. And they, over 15 years, made some strong progress. The study ended in 2014, so about 10 years ago. But they were able to enroll about 1,144 children into their study. Of course, the goal of the study was to improve our understanding of acute liver failure in children. Overall, there were so many gaps in our knowledge. Even basic questions were not able to be answered. So that we do owe a lot of gratitude to the individuals that led this at that time, including Dr. Rob Squires, who was the main lead for the PALF group. He's since now retired from University of Pittsburgh Medical Center. The basic definitions have not changed. We understand that acute liver failure is defined by not having any signs or symptoms or history of chronic liver disease within 6 weeks of the presentation of the child. And of course, the definition of coagulopathy is very direct. If you have an INR of greater than or equal to 1.5 with encephalopathy or encephalopathy, like we say in the US, or a INR of 2.0 or more without encephalopathy. So, of course, these have to be post vitamin K being supplemented. So overall, this is the basis of the talk today, the information that was generated from the PALF group. And when we looked at the etiology, the causes that were presented, once all of those 1,000-odd children were accumulated, we saw that still there was a large group of indeterminate, right? We have the paracetamol or acetaminophen group of APAP as it's outlined here. A lot of them recovered, as in the dark blue. There were some that got transplanted, which is in purple, and then very few in the Tylenol, acetaminophen, paracetamol group that unfortunately did not make it in red, passed away. Similarly, you have metabolic disease, autoimmune, viral, drug toxicity outside of paracetamol, acetaminophen, gestational alloimmune or iron storage disease, and HLH, and so forth, and a large basket of others. But again, there's a large constituency of indeterminate. And the indeterminate constituency here is depicted in this pie chart in purple, which is almost 43%. So of the 1,100 odd children in the PALF study group, almost half we still did not know the cause. And that is the question that we still move on with in the last decade. It was set very nicely by the PALF study group, this unknown we still have to solve. If you look at overall the milieu, the one thing that stands out, this slide, of course, is courtesy at Burns from CHOP, Children's Hospital of Philadelphia. There is a cytokine storm. And this cytokine storm has been almost a slippery slope or a transitional situation where the mechanism of inflammation depends on the disease and therefore reflects on the treatment offered. On one side of the spectrum, you have hemophagocytic syndromes like HLH, where we even need to do sometimes bone marrow transplant. And on the other extreme is more environmental, not induced by immunity, but sepsis, bacterial infections, of course, more amenable to antibacterials or antimicrobials. And everything in the middle is like a slippery slope, a sliding scale, going from immunodeficiency to mast cell activation to EBV-driven secondary HLH and so forth. And on the bottom, the treatments we offer go from, again, the antibacterials to immune supplementation, corticosteroids, specific anti-cytokine agents, cytotoxic drugs for HLH and bone marrow transplant, as I mentioned, at the extreme end. So we saw the picture from the PALF study group. So this is a more of a question which is self-answered. Of course, we do need to worry about liver transplantation in acute liver failure. And in this column, of course, you are looking at the different reasons for liver transplantation in children, and ALF is in the list. And when we look at the color coding of all the children who get liver transplantation, acute liver failure is not a small number. It is a significant number here in purple in this pie chart. And so, for example, in the United States, we do about 600 pediatric liver transplants a year. About 100, 1/6, are going to be for PALF. So it is definitely something of importance overall. Within that construct, sometimes we focus on the neonatal grouping of pediatric acute liver failure. And when we talk about neonatal, we're talking, of course, of the first 8 weeks of life. Very difficult to assess encephalopathy and encephalopathy. And so Professor Peter Whittington, who was one of my mentors back when I was in training at Chicago, Northwestern Children's Memorial, now called Lurie Children's, he set up a cutoff of 3.0 as a definition for neonatal acute liver failure. So this becomes a little bit of a subset. So NALF is a subset, of course, of PALF, wherein we are dealing with a separate version of disorders. The one that pops out at us, of course, is gestational alloimmune disease, or GALD, which used to be previously called neonatal hemochromatosis. And we'll talk about that a little bit more, but others are listed here. I won't go through the list. So in terms of gestational alloimmune disease, this is very critical for pediatricians because this is a conundrum. At this age group, when you have a 3-kilo child, even the best and the strongest liver transplant team is going to have some trepidation of offering liver transplant. So can we do something for these children becomes very important without transplantation. So very, very apropos to our topic today. We are talking about children who are usually within the first 72 hours of birth. We're talking about presentations where we have very common, more than half of the children have ascites, have a PDA, not uncommon to not have hepatosplenomegaly. It's very rare. INR profound, 7, 8 I have seen in terms of presentations. And of course, an elevated ferritin, somewhere in the 1,000+ range, but less than HLH range. And very, very high AFP, sometimes even more than 300,000. And what we are thinking about here is that the ALT, AST are not elevated. They're usually under 100. Very profound coagulopathy and very profound AFP elevation, almost like the fetal protein AFP that was being produced by this immature liver never stopped. And the ALT and AST that are supposed to be produced, the switch that has to happen from fetal liver protein production, enzyme production of normalcy of adulthood or newborn ALT doesn't actually switch over. So when we think about this, we're talking about relatively preterm or small for gestational age births. And of course, we talked about the coagulopathy and ascites, but also hypoglycemia. So normal AST or ALT or normalish ALT, AST, typically not above 100, elevated ferritin, very high AFP, and some cholestasis. No changes in lactate pyruvate, by the way. So that is the presentation of gall or gestational alloimmune disease as a neonatal acute liver failure situation. We're looking for iron in extrahepatic tissue. So it is not only hemochromatosis of the hepatocyte that we are going to be able to diagnose this disease. It has to be present in pancreas or spleen or heart. Or you can find it in the buccal mucosa. So you can stain after a buccal biopsy for iron in a buccal tissue piece. An MRI is also useful if you cannot or do not have expertise in terms of ENT or somebody else like dermatology that can help you do a buccal biopsy. This is from their JCEH paper from 2013. Amy Feldman and Peter put together this stepwise process, very straightforward, these two things being the most important. C5b9 staining immunohistochemistry is not typically available in most centers. So in treatment, we understand this is to be the game changer. We used to talk about in the days gone by before we understood this to be an alloimmune disease with antioxidants, thinking iron was the culprit. However, what Dr. Whittington made us understand was that iron is the presenting symptom, so to speak, is the side effect of the problem, not the cause of the problem. So when you understand this to be a gestational alloimmune disorder, one understands why giving immunoglobulin actually should be helpful by binding the excess antibodies that are being secreted. So IVIG and double volume exchange transfusion, and some concept of whether the antibodies can be transmitted through breast milk. So breastfeeding has been questioned in this situation. Transplantation for the children that do not respond to IVIG and double exchange, auxiliary transplantation, places like Rela Institute or King's College have developed, or even in the US, Columbia with Dr. Cato, Professor Cato, they have expertise in auxiliary transplantation, but monosegment more places have done. The outcomes with neonatal hemochromatosis versus other causes of neonatal acute liver failure still are less. They may not be significant in terms of statistical, 0.7, 0.8, you can see the p-values, but you can see a trend here that in the early 30 days period, there is a slight trend towards less significant outcomes. But statistically, truly speaking, no, we could not prove that, the data does not prove that there's any difference. Monosegment reduced left lobe, monosegments we talked about, These are very specialized, and hopefully large centers in your country also can claim to be able to do this. So I hope we understand that we are all on the same page, that liver disease is important in children, even in infants, in neonates, and therefore we can move past the why of discussing acute liver failure, but get to the what of acute liver failure in children. So when we talk about in the US context, how we allocate organs from the United Network for Organ Sharing, when you are in fulminant liver failure, we already talked about the 6 weeks definition. If you are ventilator dependent or on CRRT, CVVH dialysis of some sort, and you fit the definitions of ALF, you will get a status of 1A, which puts you at the very top of the list for organ allocation. The question, of course, becomes, is this the only way to decide if you are so bad that you are a status 1A that we can predict and put you on the list? What we recently have done at CHLA is come up with a scoring system called the CHLA Acute Liver Failure Score. This was led by one of our transplant surgeon scientists, Dr. Juliet Imamoli, and her group, where we can take admission laboratory tests, albumin, total bilirubin, and ammonia, and put this into a calculation. The CHALF score is calculated using this very, for me at least, very complicated algorithm. However, there is a simple calculator available online. You can go to this website, USC Transplant Lab website. You can take a screenshot. There's also a QR code I can share in the meanwhile. When you put in these 3 different metrics, albumin, bilirubin, and ammonia, total bilirubin, mind you, it will pop out a score from this calculation. And the score ranges from 5 at the lower end to 60 at the higher end. What we have found, we had a training cohort of data set, which was our own data set of acute liver failure at Children's Hospital Los Angeles, which we used to make the score system, the scoring system. And then we validated the scoring system using the PALF study group, the NIH cohort of the 1,144 children collected from 1999 to 2014. And that validation cohort, again, was strong in terms of its prediction of survival without or higher mortality without liver transplant. So why and what we would like to use the score for is to be able to say that if the score is more than 30, then it predicts a lower chance of survival without liver transplant and higher mortality, higher death possibility. However, if the score is less than 30, then you have a higher chance of survival with native liver. The ability to do this on admission lab score, not prognostication over time as to different labs being collected, but at presentation is the key part in this scoring system. So we hope that this will allow referring of children from outlying hospitals to transplant centers more quickly if the score is detected to be more than 30. So when you are able to use that, where do we go from there? My question always has been, when is transplant not the correct choice for acute liver failure? How can we make sure that we change the paradigm of going away from transplant? And again, highlighting Dr. Imamoli and one of our trainees here, she really worked on this in Dr. Imamoli's lab, Dr. Joanna Asher Bartlett. This data set was presented last year in November at the liver meeting at AASLD. And she talked about how an analysis pipeline was developed. There's 25 markers in this liver-specific panel where they used immune phenotyping of T cells, myeloid cells, Kupffer cells, and was able to understand how these different cells are organized within the data set, not just how much of the cells are there, but how they are resolved spatially in contrast to each other, in situations to each other. The comparison was within acute liver failure, did you survive or did you get liver transplant? And is there a difference between those two groups? The hypothesis that the group had was that you would be able to identify through this pipeline a subpopulation where you can predict these two different outcomes, survival with native liver or liver transplant. So let me show you the immunophenotyping or imaging mass spectrometry IMC pipeline that was developed by Dr. Imam Ali's lab. So we had, again, Children's Hospital Los Angeles, children who had undergone liver biopsy at the situation of acute liver failure. And we had 58 patients. Normal comparison was, of course, needed, but children, 25 of them who had a response on their own and survived without liver transplant, and 13 who had acute liver failure but ended up needing a liver transplant. Go into this imaging mass cytometry, mass spectrometry device, you result with single cell analysis where you can cluster these cells, and then we were able to do phenotyping and spatial, three-dimensional spatial analysis and predictive modeling from that analysis. And this paper came out in scientific reports about 6 weeks ago, where we now have the methodology shared with the general community, scientific community, how to study clinical liver disease through what is called, this whole thing is called together, single cell transcriptomic data. And when you do these single cell data, what you see is different distribution within the three dimensions of normals. You can see how, just like the most prominent color for me, I'm not an immunologist, so even I can see this, is blue here is less, and blue here is more, and that's mostly macrophages. And similarly, there are differences in all of these different subtypes of immune cells between normal and acute liver failure. Not surprising, right? You have a child that is normal, it's liver, versus somebody who is in acute liver failure in extremis, they're going to have more inflammation. However, the more interesting thing was, can we distinguish the ones that survive versus liver transplant? And here again, the big groups of normal versus acute liver failure, high macrophages, some changes in monocytes, significant statistically, and in CD8 positive T cells as well. Now, within the CD8 positive T cells, further delineated was individual cells that were Tregs or HLA-DR positive CD4 positive cells. And when you looked at those, they specifically had a marker of immune exhaustion called PD1, PD1 positive, HLA-DR4 negative. Now, within this beautiful picture, you can see that in normal, none of these cells are there. And in acute liver failure on a slide, we can find these yellow highlighted PD1 positive, HLA-DR negative CD4 positive Tregs. The hypothesis the team put together was that these differences in this inflammatory milieu will be associated with clinical outcomes. So let's see if that was true. Now we are focused on the survivors versus those that ended up in liver transplant. And truly, there was a difference here, at least in the CD4 positive Tregs. They were higher, statistically higher in the children who survived versus those who underwent liver transplant ultimately. So health, we can say from our studies that we recently have finished, there's a shift in macrophages and T cell subsets to something of a phenotype, which is specifically Tregs, which are PD1 positive. And within this subset of pediatric acute liver failure, some will spontaneously recover. And it looks like they're the ones that have these regulatory T cell population that express PD1. So it is a very interesting speculation, because if we can now identify this as the key differentiating factor between those that survive and those that go to transplant, can we actually double down on this? Can we take advantage of this finding? And having PD1 is something called immune exhaustion, right? So this is, again, I'm not an immunologist, but I've been learning about this from my friends who are, and they're talking that there are individual ages that maybe we can exaggerate this immune exhaustion phenomenon and therefore help in recovery from pediatric acute liver failure. And that leads us to what is now the next version of the national study, which initially was the PALF study group, and now led by Dr. Estela Alonso. Our site is led by Dr. Beth Carter, but nationally led by Dr. Estela Alonso here in the middle, is called the Treatment of Immune-Mediated Pathophysiology, or TRIUMPH trial, which is led by Northwestern's as the main site, but it is a national study where we are using immune-mediated thought processes for treatment of acute liver failure. And what they have seen, again, is similar, that there are distinguishing features of high and low inflammation between individuals who are going to resolve or not resolve acute liver failure on their own. And focusing on that big chunk, as I highlighted at the very beginning, of indeterminate PALP. If you have the cause, of course, you will treat the active hepatitis infection if you know the cause, or autoimmune with steroids and so forth, but it's the indeterminate PALP that we want to treat. And they too are focused on the CD8 positive T cell infiltration in these acute liver failure children. What TRIUMPH is a double-blind, randomized placebo-controlled trial, and they're using either high-dose steroids or thymoglobulin, suppressing this and moving individuals similarly to what we're thinking towards immune exhaustion through these mechanisms. The primary endpoint, of course, is survival with native liver at 3 weeks. This is across the continent, all the different centers, including ours on the West Coast, you can see, that are part of the TRIUMPH study. And at this point, I will stop and happy to take any questions from the group.
Thank you so much, Dr. Rohit. It was very nice lecture, and really we learned a lot from you. Maybe we'll open the floor for questions. We'll start with Dr. Mohammed Ayub.
Of course. Thank you for your attention and look forward to the questions.
Sure.
Hi, Dr. Kohli. Thank you very much for your wonderful lecture. I have two questions, actually. One related to the CHALF score. So if you probably know that usually when we use the PELT score, we can quantify the risk of mortality within a 90-day period. So that calculation that we get, whether it's a PELT of 35 or 40, it reflects 90-day mortality. Can the CHALF score give an idea about time period for risk of mortality without transplant? And my second question was about IPALF. I personally find it very frustrating to see a patient in front of me who's basically going into end organ damage and end organ dysfunction without doing anything. And so it has happened before where we feel like we're stuck and we start steroids. And so we don't usually have many fancy ways to know whether this is cytoregulatory T cells going into the liver and causing all the hyperinflammation that we see. But I just wanted to ask you, in terms of clinical practice, when do you pull the trigger and start steroids? There's a paper by Stella Alonso in Pediatrics that discusses this. But there's a very wide range of dosage, going anywhere between 2 per kilo to 10 per kilo, almost like pulsing a patient. And we're also concerned in these situations that these patients can develop or they can basically get infection, and that pushes them more into end organ dysfunction. Thank you.
Thank you for your questions. Those are very, very critical questions. The CHALF score is very different from the MELD or PELD. The goal of the group when we put together the CHALF score was not to give a timeline. It's not a repetitive measure of trying to see how the disease is progressing. A MELD score changes over time, a PELD score changes over time, and therefore you are able to use it to allocate organs, just like you said, based on how quickly we can predict the child or the adult is going to reach a non-transplant survival. The CHALF score is intended as a triage tool for a site where a child presents, which may or may not be a transplant center. to help us understand whether or not this child is going to need a transplant, period, versus this child is going to spontaneously recover from the acute liver failure incident. Therefore, it's not a prognostication score. It is not a predictive tool for timing. It is a yes/no answer for native liver survival or going to transplant, high mortality risk. And that, again, was based on our cohort locally first, and then validated with the NIH PALF study group cohort. But there is clearly limitation that both of these cohorts, the Los Angeles cohort and the PALF cohort, are from the western part of the globe and predominantly from North America. PALF had, I think, a United Kingdom site, but other than that, it's predominantly North American. But both of those areas are still very low indemnity for hepatitis A associated acute liver failure, which in many parts of the world is a large piece of the pie for PALF. So I think our next stage is to actually reach out and through interactions such as these, we are trying to develop a global network and pool our cases together to retest the CHALF score in different environments, tweak it to be based on the local environment and the local insults for PALF, etiologies for PALF. The second question you asked is a very tough question. We depend on certain markers of immune dysregulation to decide when and if to use high-dose steroids. This is predating our participation in the TRIUMPH trial. Because of course now we're in the middle of the trial, so we go by the book for the trial's intake and exclusion criteria and so forth. But before we had the trial, we were working on similar paradigms to what you mentioned, Dr. Estela Alonso or Dr. John Vukovalis from Mount Sinai now, before he was in Cincinnati. They have been studying immune dysregulation around PALF for quite some time, and using IL-2 soluble receptor, NK cell function, perforin, granzyme. If we have access to those studies in good time, say within 2 to 3 days, we can use those. If not, then we have to lend ourselves to more readily available tests, such as ferritin levels and so forth, to understand if there is immune dysregulation. And if there is immune dysregulation, then we pull the trigger in the absence of any other, of course, as you mentioned, IPALF, so indeterminate PALF, any other etiology identified. And sometimes, yes, we will also hesitate because of the potential for superinfections and add coverage for antibiotics, antifungals empirically for a short period of time. So long as nothing grows, then we take those off. But definitely using those tools, which are clinical, but again, not exceptionally readily available everywhere, I take that into consideration. But those are the tools we use because we have access to them within 2 to 3 days turnaround.
Wonderful. Thank
Okay,
you.
so we have, thank you, Dr. Mohammed. We have another question from Harry.
Hi, Dr. Kohli. That was an excellent presentation. I have two questions. One is, in your cohort, have you guys looked at a subsection of your IPALF patients who get hepatitis-associated aplastic anemia? I find those patients obviously very interesting, and there has been some success with good immunosuppression in them. And then also just about your thoughts around the TRIUMPH trial in general, which is using very broad immunosuppression, but your research really highlights the idea that if we can find something really specific to these patients, we can give them something that's not going to potentially wipe out their entire T cells. And I'm interested in your thoughts and kind of what your research is at that point.
So great questions, Harry. Nice to hear your voice. I think there's a real tension between how broad we have to go today and how our very, very fast-moving scientific understanding of IPALF is bringing us towards more precision medicine. So when the PD-1 positive things have popped out, of course, these need to be validated, but a lot of us will know that there are actual agents that will modify PD-1 subtypes already being used in cancer biology. So there are already FDA-approved agents out there. So your question is very appropriate. I don't think we're there yet. We have to first complete the TRIUMPH study, and then by then, hopefully, we will have more robust analysis of this PD-1 pathway and validate it in other cohorts before you can think about a trial with these as specific targets. Your first question, I understand, but I don't think I have a complete answer. It's a slippery slope. So for now, I would like to just take a step back and try to better understand the biology rather than jumping the gun and giving you my biased answer. I hope that's not too evasive, but I know it is. But I do really feel I don't want to speak out of turn.
No, I appreciate it, and I appreciate your first answer as well. Thank you very much.
Perfect. I have here a question in the chat. As in the definition of the pediatric acute liver failure, the cut limit, I mean the response to the vitamin K. So if the child came with the INR of 5 and you give a vitamin K and it turned to be like the INR now is 2. Do you still consider this as liver failure, or do you think this is a response? And how many doses you give till you said, no, this is liver failure or this is a response?
So let me repeat back if I heard correctly. You said it went from 5 to 3 INR?
Yeah, so initially he came with a 5 of INR, and then you give vitamin K, came down to 2.
Oh, 2.
Yes.
That's why I wanted to clarify. Yeah, if you and is there encephalopathy or no encephalopathy?
No encephalopathy.
Then it's a response, right? The child, if it's 2 or above, we're defining that as liver failure. But if it's 1.5 or above with encephalopathy, we're defining as a liver failure. So at 2, you're at kind of the border for the definition. So, and you've only given 1 dose of vitamin K. So I would say that it's a pretty decent response. I would give another dose and closely monitor the child. Of course, you're looking for other signs, right? Is there hypoglycemia? Is there hyperammonemia? So those will help us as well. Overall, I feel that this is a clinical response, which we should then give the 2nd and 3rd doses of vitamin K. But do not move the child out of intensive care. Keep your eyes close. And if the child score is high from initial numbers, make sure they're close to or at a transplant center.
Perfect. The other question here in the chat about using steroid, as you mentioned, in acute liver failure. And I'm not sure if you mentioned this, but it's mentioned here that do you use it as a cocktail therapy for pediatric acute liver failure initially? Do you have to clear the child from infection before using the steroid or not?
So
Okay.
I'm not sure what the individual asking the question means by cocktail therapy. I'm assuming that they're talking about having a broad antibacterial, antimicrobial coverage along with the steroids. And I think until 48 hours of negative cultures, there is no downside to providing that coverage, umbrella coverage. But once you're past 48 hours, there are significant downsides to having antibacterial treatments which are not actually of use directed towards a specific agent. So I think we have to be judicious and back off as soon as we know that there is no big bacteremia, fungemia at play.
Perfect. There's another question by Dr. Tawfiq. Are you aware of any comparison between the macrophage and the type of T cells in acute liver failure compared with the DIC due to sepsis?
We have not done that. That's a good question by Dr. Al-Lawati. I think because we focus so closely on the indeterminate PALF subgroup, and within that group, who was surviving and not, we didn't take into account the children who have sepsis-induced or other causes induced. But it's a great question. whenever you broaden your indication, you are going to get more and different understanding. So definitely something we should look into. That's a great point. However, of course, we know sepsis will be treated differently as well.
Other question about the role of N-acetylcysteine in non-paracetamol acute liver failure.
Very controversial. The larger studies that were done, multi-center, did not show any efficacy. And the smaller studies from King's College have shown efficacy. So is there a downside to NAC? Maybe not, but does it distract us from true treatments of indeterminate PALF, which are based on scientific premise that we just discussed today? Probably it does. So it makes me think more of the antioxidant cocktail we used to do before we understood NALF, or specifically GALD, or neonatal hemochromatosis. In those days, we were giving vitamin E and selenium and so forth, and thought we were doing the right thing because we were responding to the symptom, until we finally understood the pathophysiology, and then we shifted our treatment and actually saw a difference. So I think my bias is that this is a distraction. So let us focus on the science and move forward with that. We've already had multi-center studies that showed that NAC really did not make a difference.
Perfect. Second question, what's the maximum dose and the frequency of IVIG for GALD treatment?
So just going back to the pathophysiology, right? So if we're talking about a pregnant woman who has had first trimester losses, or a baby proven to have gall before, and you're doing a prevention, that is different. I think that's not the question. But the question is for the baby that is born with gall. Here you're going to give maybe 1, maybe 2 doses of IVIG, because the whole goal is just to mop up the freely floating antibodies that the mother has transmitted to the child. More than that, it has not been, 1 gram per kilo is the dose, of course, but more than that has not been shown to be more effective or not. And the same thing also for the double exchange, because doing it once in conjunction, in parallel with the IVIG, should be enough. Have I done it more in desperation? Yes, I have done double exchange twice, and I've given 2 doses of IVIG, but I had to convince myself that I actually am doing something good.
Perfect. Here I have another question in the chat. Child came with acute liver failure. He has family history of Wilson disease. Do you give a trial of chelating agent before thinking about transplant?
So you're talking about a suspected fulminant Wilson's presentation. We're not talking about indeterminate PALF. And if the other signs are indicative of, especially in a consanguineous setup for hereditary diseases like Wilson's disease, if you have, sometimes these can be red herrings too in acute liver failure, but if you have a significantly low ceruloplasmin, if you have normal ALK-Phos, if you have ascites, my bias would be, as soon as you can safely get a transjugular biopsy and quantify the copper, do that. Once you know that is high, go ahead with chelation. There are downsides to chelation. So without quantified copper, I would find it hard to press empirically to give a chelation in that situation. But because you have such high suspicion with the family history and the presentation, the risk of the transjugular biopsy, I think, is not as much as the benefit we will get about from the biopsy and the quantification in the liver. So I would push more for the definitive procedure in such a case, so we can move quickly to chelation if it is the right thing to do.
Dr. Rohit, you just talked about doing liver biopsy in acute liver failure. What other condition usually you think about doing liver biopsy, and what is the ideal way to do it and ideal time?
Well, it depends on the size of the child. If we do not have a significant etiology, you saw that we have a large cohort of liver biopsy tissue from children who have PALF. And that is because we have typically been open to doing this. If the child is less than 10 kilos, then transjugular is not going to be possible. At least at our center, we're not able to do that. So then we will do either interventional radiology or more likely an open liver biopsy with pediatric surgery, where they can control the bleeding and manage the ascites and so forth with visualization. The benefits we have seen are self-evident, where if we can pick up a diagnosis and there's a treatable condition, then we can move forward. Historically, the reason we became comfortable doing it with this population was our leader for the hepatology group at that time was Dr. Danny Thomas, may he rest in peace. He felt that other indicators of reversal to of the indeterminate PALF group, the reversal of the disease to getting native liver survival versus not, could be predicted by the biopsy and the extent of necrosis of hepatocyte loss on the biopsy. And he put a lot of faith into that. We are hoping that today, because of all of his work, we are able to use this CHALF score and replace the liver biopsy with that CHALF score.
Perfect. Thank you so much. Any other questions from the audience? Please feel free to speak up.
Well, thank you so much for the opportunity. This was wonderful. Hopefully, at some point, we can have you guys visit and also participate in our validations of our thought processes for CHALF and other opportunities for research together.
Thank you so much, Dr. Rohit. It really was a pleasure to have you with us. And probably next time, if you can promise us to present to us about non-alcoholic fatty liver disease. And we really appreciate your presentation, and we really learn from you a lot. Thank you so much. And thank you for all the audience here. And we'll see you in 2 to 3 weeks, inshallah. Yeah,
Bye-bye.
bye.
Shukran.
Thank you.